Hello friends, now I will be talking to you about hypoxia. So before we discuss hypoxia, let's see what the normal values. Normal PaO2 is 95 to 102 millimeter of mercury, and normal PaCO2 is 40 to 45 millimeter of mercury, and whenever PaO2 goes to below 60 millimeter of mercury, we call as either hypoxia, or we also call it to be respiratory failure. Okay. So the prerequisite for hypoxia or respiratory failure is low level of PaCO2. Now let's see what is the type 1 failure and what is type 2 failure. Type 1 failure, type 2 failure, PaO2, PaCO2, it is below 60 millimeter of mercury. So in both type 1 and type 2, hypoxia is there. But regarding PaCO2, it is normal, that is, it is in the range of 40 to 45, but it is more than 45. So difference between the type 1 and type 2 is hypercapnia occurs in type 2 and CO2 level is normal in type 1. But there is one more difference, that is PaO2 minus PaO2, the gradient. This is increase in type 1, normal in type 2, respiratory failure. Now before I proceed further, let us learn what is this gradient is there. A is alveolus, and normal oxygen pressure in the alveolus is, let's say this is the alveolus A, and the pressure here is 100. This is arteriole A, small a. Normal arteriole pressure is 95. Okay. So normal PaO2 is 100 and normal arteriole is 95. So gradient is how much? 5, normal gradient. In type 1, this gradient is increase. In type 2, this gradient is normal, right? So we have two differences in type 1 and type 2. One is about CO2 level, hypercapnia, normocapnia, gradient normal, gradient is increased. These are the basic concept about the hypoxia. Now let me explain to you two terms, some basic concept about. One is ventilation and other is perfusion. What do you mean by these two terms? Here is the airway. Ultimately from airway, oxygen come to terminal part of the respiratory, that is alveolus, A alveolus. And this is the arteriole, and ultimately oxygen comes like this and CO2 goes like this. Now coming of oxygen up to the alveolus is ventilation, and coming of the blood into the arteriole is perfusion. Suppose this alveoli collapse or there is a airway obstruction. Let's talk about patient has COPD. So in COPD the airway they go into bronchoconstriction. So thereby air is not able to come to the alveolus. So we say it's a type of hypoventilation. Now in pulmonary embolism, pulmonary arterial embolism, artery is blocked, so blood will not perfuse, it will not come to capillaries or arterioles. So we say less perfusion is there. So this is the basic about what do you mean by ventilation and what do you mean by perfusion. So having learned the basic concepts, let us know what are the causes of hypoxia. Remember, hypoxia means PaO2 less than 60 millimeter of mercury. Causes. The causes first of all decrease FiO2. Let us learn what do you mean by FiO2. Basic concept about FiO2. Well, we are all breathing from the atmosphere. Okay, in the atmosphere the oxygen concentration is 21%, rest all is nitrogen and other gases. So normal breathing, what you and me are breathing, we are taking 21% of the oxygen from the atmosphere. In the scale of 100 it is 21. In the scale of 1 it is how much? 0.21. So we call this as normal FiO2. Okay. Now anything where the oxygen is less, the FiO2 will be reduced. Now the question is, throughout the world, whichever place you are sitting in the normal city, okay, FiO2 is 0.21, but if you go to very high hilly areas, then FiO2 goes down. So reduced FiO2 typically occur in very high altitudes. So there FiO2 is less than 0.21. So you can write down reduce FiO2 high altitude. That's why when you go to very high places, some patients they do have some respiratory difficulty. So now you are clear about it, what is FiO2 and how and where it is reduced. Second is hypoventilation. That means, as I told you, the air or oxygen is not coming to alveolus. So it can happen in which condition? It can happen in condition like myasthenia gravis or drug overdose. So in this condition, remember, in myasthenia gravis the diaphragm get paralyzed or respiratory muscle become weak. So there is no movement in the respiratory muscle. You know it very well that diaphragm plays a major role in inspiration. 80% of the inspiratory force is due to diaphragm. 80% air goes into the lungs due to diaphragm. If diaphragm get paralyzed, there will not be any air movement, there will be hypoventilation. Similarly, if you have given anesthesia drug overdose where you paralyze all the muscles of the respiratory, so drug overdose will lead to hypoventilation. Third is the shunt. Shunt means here is the alveolus, here is the pulmonary arteriole, here are the capillaries, and here is the venule. At time the blood may flow directly from the arteriole to venules. It is not coming to capillaries. So obviously there will not be any exchange of gases. So this is so called shunting of blood. So shunting of blood occur in condition like atelectasis, when all the lungs is collapsed. Intrapulmonary shunt, in the lung itself arterial blood is going into venous blood without going into exchange in the capillaries, or right to left shunt in the heart. Classically what we see in all cyanotic congenital heart disease like tetralogy of Fallot. What is happening? The blood is directly going from right side to into left side. In the heart only, the heart blood is not going to lungs, so we are getting shunt. So all shunt will lead to hypoxia. Then ventilation perfusion mismatch. This classically occur in obstructive airway disease like in asthma, COPD. Air is not coming to alveoli or less air is coming, so ventilation perfusion mismatch is there. Interstitial lung disease, again because of disease in the interstitium, blood is not able to come to oxygen is not able to come to arterioles, and in pulmonary embolism again there is no perfusion. So in nutshell, there are four mechanisms by which hypoxia can occur. To have a quick recap: reduced FiO2, hypoventilation, shunts, intracardiac or intrapulmonary, and of course ventilation perfusion mismatch. Now how to approach a case of hypoxia? So where we have one patient who is coming with hypoxia, how to approach? So any hypoxic condition, best initial test is always arterial blood gas analysis, ABG. This is the best and the most accurate test. So how to approach? We got ABG and we are getting PaO2 less than 60, that confirm he has hypoxia. So how to approach this case? So we have PaO2 less than 60 millimeter of mercury, that confirm hypoxia. Now we check PaO2. We discussed just now that normal PaO2 is 100, normal PaO2 is 95. The gradient is 5 millimeter of mercury in a normal person. So then we check the gradient. Then what is the gradient? Is normal or increase? Okay, this gradient. So if gradient is normal, then what we do? We check CO2. Is PaCO2 increase or not? If it is not increased, that means this patient has reduced FiO2. That is this one, number one. number one. Reduce FiO2 is the main reason. But if it is increased, then it is hypoventilation. This is the reason. Hypoventilation. Right? And if this gradient is increased, then is this hypoxia correctable with oxygen? That means you give oxygen from outside. Can you correct this hypoxia? No, then it is shunt. Like in tetralogy of Fallot, you keep on giving oxygen, then it doesn't affect much, doesn't have much of the benefit. Reason being, directly the blood is going from right heart to left side of heart, so not correctable. If it is correctable, then it is VQ mismatch, this one VQ mismatch. So in obstructive airway disease, interstitial lung disease and pulmonary embolism, we have, you give oxygen from outside, improvement occurs. So friends, in summary, we talk about gradient, normal, increase, and CO2 normal or increase or correctable with oxygen or not. So now how to treat a case of hypoxia? Treatment of hypoxia comes to us. First thing is give oxygen. Give oxygen. Now how to give oxygen? This is, suppose patient has type 1 failure. That means there is hypoxia with hypocarbia or normal CO2. You give high flow oxygen. High flow oxygen. What do you mean by high flow oxygen? You give 8 to 10 liters per minute. But patient having type 2 respiratory failure, that means there is hypoxia with hypercarbia, you give low flow oxygen, 2 to 3 liters per minute. Why is it so? If you give very high amount of oxygen in type 2 failure, so large amount of CO2 will be produced, but body has a disease where the body is not able to expel or expire CO2. So there will be sudden further increase in CO2 and patient will go into CO2 narcosis. So when we are talking about oxygen therapy, the first and the best initial treatment, but there is a condition that in type 1 you give low flow and type 2 you give high flow oxygen. Give oxygen. Then you treat the basic cause. That's the next thing to be done. Like suppose patient has asthma, you treat asthma, COPD, pneumonia, whatever the cause is, you have to treat. Patient is in very high altitude, where his FiO2 is less and he is in a severely hypoxic. Of course, you have to shift the patient to the C side level. You have to bring down from very high altitude to the normal ground level in the normal cities. Okay. So treat the basic cause. Now if patient is on ventilator and he has hypoxia, what we can do? Either you increase the oxygen parameters. What we can do? We can increase FiO2 or increase PEEP. If normal P, as I told you, normal FiO2 is 0.21. You can go up to 0.50 maximum. Normally we don't go above 0.5, because if you go above 0.5, it itself lead to toxicity. So we can increase FiO2 to some, so that more and more oxygen is delivered to the lungs. And PEEP, when we are giving you the PEEP, positive and expiratory pressure, it will try to keep the alveoli open. Alveoli will open, that means more and more diffusion will occur into the capillaries. But if PaCO2 is increased, then again patient on ventilator, how we can remove CO2? You can increase the respiratory rate and you can increase the tidal volume. This is how you have to take care of a patient of hypoxia or hypercarbia on ventilator. Thank you very much.